Here's what I hope to do in the next 25 minutes. What I want to do is I want to talk about crucial factors related to complex PTSD as opposed to regular PTSD, I suppose. I want to start talking a little bit about the biological changes that are associated with chronic trauma and stress. This includes both neuroendocrine, neurochemical, and ultimately neuroanatomical changes that can happen. We'll also spend a little bit of time talking about two presentations of PTSD according to Lannis, both activated and blunted PTSD presentations that apply to complex PTSD. And then at the end, I'll talk about a tool that you can use that many of you are probably familiar with to identify folks that may struggle with this. Really briefly, the simple PTSD diagnosis, although nothing is ever simple with trauma. Criteria A, you directly experience something traumatic, and I'll say why that traumatic is in quotation marks in a moment. You have some intrusion symptoms, flashbacks, nightmares, things of that nature. Avoidance symptoms, you don't want to experience that, so you avoid situations, people, places that remind you of the trauma. You have some negative alterations in mood and cognition. Suddenly you're really irritable, you have hopeless thoughts about the future. The duration has to be for at least more than 1 month. Have impairment in your life in some way, and it's not explained for by other things like medical problems, thyroid issues, things of that nature. But let's talk a little bit about how do we define trauma to begin with. Is it objective or subjective? Are only some things, some experiences considered traumatic? Well, most people in the research talk about big T or little t trauma. Big T traumas being things that most of us would recognize as being traumatic: car accidents, physical assault, sexual assault, things of that nature. But how about something like bullying? Where does that rate? Most, I think, have kind of decided that trauma is, it's like beauty. Although it's not beautiful, it's an eye of the beholder experience. So the working definition that I'm going to use for trauma today is that trauma is a normal survival response, fight, flight, freeze, to an abnormal survival threatening event, whether that threat is real or perceived. Now, I'm going to be talking a lot about how this relates to kids and adolescents, but for those of you who work primarily with adults, hang with me because I think you'll find a lot of the information that I'm going to present will also apply. But what basically happens with trauma, as it relates to kids at first at least, is that reality collides with our shoulds, our working model, if you will, of the world. Parents shouldn't hit their kids, but some do. Uncles shouldn't sexually assault young children, but sometimes they do. And so what we see is a very big clash between the way the world should work and what actually happens. And how does the child, how does the adolescent, how does the person make sense of that discrepancy? So there are two things here. One, the child has to make sense of the trauma itself, what happened. And then second, they have to make sense of their response to the trauma. When I was 17, I waited tables down in Texas at a place called the Black Eyed Pea, which is this open restaurant, cafeteria style. And as I was waiting tables, he wasn't at my table, but the table next to the one I was waiting on, there was a gentleman who had a heart attack during the middle of dinner rush, and they attempted to resuscitate him, ambulance came, the whole 9 yards. So for me, it was pretty traumatic, and I remember afterwards, I was shaking uncontrollably for at least an hour. So there were two things I had to try to make sense of. One was somebody dying during dinner rush, something that, by the way, shouldn't happen. And then second, my response to that trauma, the uncontrollable shaking. Now, if a child or an adolescent is not helped with this, and by the way, they're not going to come up to us and ask us for our help, usually, because they're busy avoiding, they're going to come up with two explanations to understand this discrepancy. One is they're going to say, well, the bad thing, didn't really happen, or I didn't really feel that way. So they basically become cut off from their emotions. They become strangers to themselves. They learn to not regulate in that manner. And second, they're going to come to the conclusion that they somehow deserved it. They accuse themselves. When I did my postdoctoral fellowship, I was at St. Jude Children's Research Hospital, which specializes in cancer. And even though doctors, people like myself, clergy would all tell kids the same thing, which is cancer is not your fault. There's nothing you did or did not do that created this. This is a mutation in your cells. It just happens. Many of these kids, even kids from really good homes, would reject that explanation. They would reject it, you see, because the idea that crap happens is a very unsatisfying psychological explanation, isn't it? And so kids throw themselves under the bus. They say, well, it must have been something that I did to create this thing that could kill me. And that's how the human mind sometimes works. We'll incriminate ourselves if it helps us to understand a discrepancy, even if it doesn't lead to good outcomes. Okay, so understanding, there's two things we got to do. We got to help the kid, the adolescent, the adult really, to understand the trauma itself and their response to the trauma. So understanding the trauma itself, the things on this list load higher for ongoing complex PTSD response. First of all, we know that interpersonal trauma weighs more than non-interpersonal trauma. What does that mean? It means if there's an earthquake and you're buried under rubble, that is traumatic. But on the whole, being mugged by another person is much more difficult of a thing to wrap your brain around. We also know that it's harder to deal with it depending on how close they are to the perpetrator and how frequently it happened. We also know that it depends on their age. We used to believe that kids younger than the age of 3 were basically ignorant of trauma, but we now know that the opposite is true. They may not be able to access the trauma because the verbal parts of their brain were not online at the time, but they do get encoded in the emotional centers of the brain, which makes it even more tricky to be able to treat. Were others supportive or validating after, or did they ignore and minimize what happened? A woman I'm working with right now was assaulted by a homeless gentleman in a bathroom stall. We were able to process through that really quickly. It's taken much, much longer to process her mother's comment that somehow she deserved it. So did adults take steps to protect and rectify what happened? Or did they take steps to cover up? A poet by the name of Adrienne Rich said it best. She said, "That which remains unspoken soon becomes unspeakable." And then finally, what is the fallout of revealing the trauma? If a child reveals that dad sexually molested her, mom and dad may get a divorce. That may be the appropriate thing to do, but there could be quite a bit of fallout that can happen. The child's life changes dramatically. So I won't spend much time on this slide. It's in your handouts. The things on the left, the more factors you see on the left, the more likely that PTSD is not going to be a simple presentation. It's going to be a complex presentation. So next we have to have them understand their response, their fight, flight, freeze response. Now again, it's a normal response to a real or perceived abnormal event. And there are 3 major changes that happen in the system: neuroendocrine, neurochemical, and neuroanatomical. Now with neuroendocrine changes through the HPA axis, we see a flooding of cortisol that goes into the brain. Now again, remember what we're talking about here is not just a one-time incident, but many times throughout the child's life, their brain is marinating in cortisol. Next, we see a neurochemical change where we see an increase in neurotransmitters like high norepinephrine and glutamate and low serotonin and GABA. And so this becomes the child's new baseline over time. And then finally, there are neuroanatomical changes that can actually happen. Again, if your brain is marinating in cortisol and some of these activating neurochemicals, it will change the actual brain structures. What you will see is a shrinking of the prefrontal cortex, the anterior cingulate cortex, which is in lay terms, the middleman between the prefrontal cortex and the limbic system, and the hippocampus, which is involved in learning and extinction. And then what you see is an enlarging of the amygdala, which is the reactive centers of the brain. This is why many of the kids that I treat that have complex trauma also have ADHD. They also have learning disability problems over time. So here's a brief screen to identify what we're talking about here. This is from Frank Anderson's work, but it's based on Lannis. And the reference, I'll give that to you at the end. So you have a threat in the body, that's on the far left side right here, threat to the body that goes to the thalamus, and then immediately gets transferred into the amygdala in a very, very rapid fashion. Now it also activates the prefrontal cortex, because the prefrontal cortex is where we have our working memory and we're making sense of things. The problem is that connection to the amygdala is super, super fast and very unconscious, whereas the connection speed to the prefrontal cortex is infinitely slower. It's much, much slower. So what you see here is the amygdala gets activated, and then you see that the glutamate, the norepinephrine, and cortisol all get released almost instantaneously, and then you also have the additional hormone releases and all the other releases going on here. Now that all happens in the blink of an eye before the prefrontal cortex even knows what's going on. Now what ends up happening in the long run, not just for a limited once or twice, but in the long run what ends up happening is glutamate and these other chemical changes I've talked about will block the prefrontal cortex, and they'll block the hippocampus, which is involved in learning and extinction, so that they're not functioning as effectively. And those two areas of the brain are very critical, because without those areas of the brain online, how do you self-regulate? You can't. You can't. And so this becomes the dilemma for somebody that chronically goes through this. So we have two different varieties of complex PTSD. Again, remember, complex means the bad thing didn't happen once, but there weren't just episodes, there were repisodes, which is not a real word. It just means repeated episodes of either the same thing or of different things. And so you have two different types of presentations that can happen. There's an activated PTSD, and that's summarized on this slide where, oops, let's go back, where there's low cognition, they're not thinking very clearly because the prefrontal cortex isn't online. You see a high emotionality, you really recognize these people when you're sitting across from them. And also there's high physical sensations. They're prone to things like panic attacks. Now, according to Lannis, that's about 70% of complex PTSD, so that naturally raises the question, what about the other 30%? What about them? Now, this other 30%, what ends up happening is when fight and flight are not options, you go into freeze mode. Peter Levine has this great video, well, great is relative, but a video of a gazelle who's about to be attacked by a predator. At first, there's a freeze response as the gazelle finds where the predator is coming from, and then it runs and it takes off, and the predator catches up to it, and right before the predator gets it, the gazelle suddenly freezes and drops over, and it just freezes out, because apparently if you're about to be eaten, that's the appropriate response to do. When escape is not an option, you freeze up. So this is the immobilization response that we'll see sometimes, and it's also the basis of dissociation. There's this interesting relationship where glutamate will activate NMDA receptors, and we think that the NMDA receptors are the primary responsibility for this dissociative tendency that we see. But practically what shows up for these patients is all emotions become the enemy, not just the negative ones. It's not like emotions are a buffet. You can't pick them out and say, I will have joy and love and peace, and I'll leave fear at the table. No, you start numbing out from all emotions. You don't feel anything. And you get some body or intuition blindness. Sometimes with some of my complex PTSD patients, this is why they will pick out the same type of partners who tend to be abusive. It's not because they're dumb, it's because they're cut off from those intuitive sense of who's going to be safe and who's not going to be. But ironically, what is needed the most is self-monitoring, and we'll do an activity here to illustrate that. Well, what ends up happening for these folks is they also go into, you talk about fight, flight, freeze, but then there's also appease. And we think of appease as being appeasing the predator, like the gazelle's going to come up with some kind of negotiation strategy with the predator. But what I'm talking about here for these folks that are dissociative is the appease strategy isn't just the appeasing the physical predator, but also the mental construct in their mind. These folks, they present differently. I'll share with you a moment about that, but I want to go through this slide real quick first. So you still have the threat to the body that happens that gets funneled into the thalamus, and once again, you see the prefrontal cortex and the amygdala both get activated in the same way. But what ends up happening here is the prefrontal cortex and the hippocampus still are talking, right? But you see the ventral striatum that is involved in reward seeking gets activated so that the person just bails, escapes, and avoids something over the long period of time. So what you end up with is, with this more blunted PTSD presentation, is more of a numb or dissociative state that's based on the parasympathetic hypoarousal system, where you'll see high cognitive suppression. Now, what does high cognitive suppression mean? As I'm sitting with these patients and I say, wow, it sounds like childhood was rough for you, they immediately say, it wasn't that bad. People have it worse than me. You know, they have all these rationalizations that they've internalized from potentially their predators growing up. Their prefrontal cortex is online, but it's doing a suppressive functioning. It's basically repeating whatever their predators had told them. And these people, now how do you know the difference between that person and the person who has successfully resolved the trauma, right? Well, the way you know the difference is this second point here with the low emotionality. Unlike, oops, hang on one second, wrong button. Okay, low emotion. So, you know, they're not only saying, hey, everything is fine, you know, their favorite word is fine. Fine, 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 fine. They are fine. They're always just fine. And there's very low emotionality going on for them at the time. In addition to that, you ask them about their physical symptoms and sensations, and there's a sense that they're minimizing, that they don't really know anything below the neck. I sometimes call them floating heads, because they know what they're thinking, but they don't know what's going on below the neck. It's very difficult to extract that information from them, and yet they're still suffering. They're impaired in some ways. This is not somebody who's moved on from the trauma, no matter how much they tell you they're fine. This gels nicely into what some of you may know as Stephen Porges' polyvagal theory. The vagus is Latin for the term of the wanderer, massive nerve going from our brainstem down. As I think about this, you know, think of a 3-lane highway. You have the ventral vagus system, which is involved in social engagement, okay? So as many of you were taking this unscheduled break, you were out, you were hugging each other, you were laughing, you were talking. That's your social engagement system that was at place, your ventral vagal system. Now, there are some situations, like individuals with autism, that may have more difficulty accessing this part of the vagus nerve. But this is when we feel connected and safe. And by the way, not for nothing, but being disconnected is a form of trauma. So when you're feeling connected, seen, and safe, then the ventral vagal, it will be online. Now, if you don't feel seen, safe, heard, what will end up happening is it'll be perceived danger or dissociation. And that middle lane of the highway, the sympathetic nervous system that activates fight or flight and all those chemical processes that we talked about earlier, comes online. And if there is no escape, you're going to go into the dorsal vagal branch. At the very back of it, this is your parasympathetic response, where you'll disconnect, shut down, and dissociate. Many of you are dissociating right now. And you will several times. That's okay. I don't take it personally. All right. So this isn't just true for big T trauma. So far I've talked about it. I've talked about PTSD like it's a trait. You know, you're either blunted or you're activated. But it's actually more of a state that you get into. Even people that have blunted PTSD, they're very low, but then they have these spikes of trauma responses, right? And then they come back down, right? Usually maybe alcohol, maybe Klonopin, maybe Ativan, something along those lines to deal with those spikes. But we all experience this, and you experience this on a regular basis. To illustrate this, I'm going to have this slide up as I'm reading from Deb Dana's work, talking about the polyvagal theory. It's in your handouts if it's something you want to look at. But I want to share this with you. And as I'm sharing this with you, see which part of the vagus nerve is active. I'm driving to work in the morning, listening to the radio and enjoying the beginning of my day. Okay. Ventral vagal, top of the ladder. When a siren sounds behind me, I feel my heart race and immediately worry that I've done something wrong. Okay, now gone down to sympathetic part. Okay. I pull over, the police car rushes by me, I pull back out and resume my drive to work and feel my heart begin to return to its normal speed. Okay, now they're moving up this ladder again. By the time I get to work, I have forgotten about the incident and I'm ready for my day. Back at the top of the ladder now. I'm having dinner with my friends, enjoying the conversation and the fun of being out with people that I like. Top of the ladder. The conversation turns to vacations and I start comparing my situation to my friends' situations. I begin to feel angry and I can't afford my vacation and that my job doesn't pay me enough and I have so many unpaid bills, I'll never be able to take a vacation. And where are we going? We're going down the ladder, going into mobilization. I'll never be able to take a vacation. I sit back and watch my friends continue to talk about trips and travel planning. I disconnect from the conversation and begin to feel invisible as the talk goes on around me. Where are we? Bottom of the ladder. The evening ends with my friends not noticing my silence and with me feeling like a misfit in the group. I go home, crawl into bed. The next morning I wake up and don't want to get up to go to work. Still at the bottom of the ladder. I worry I'll get fired if I don't show up and drag myself out of bed. Okay, now we got a little bit of energy coming into the system, so a little bit of mobilization going on, so we're in the middle of the ladder now. You don't want to get fired. I'm late to work. My boss comments on my lateness. I have a hard time holding in my anger response. I decide I've had enough of this job and will seriously look for a new one. I begin to consider the skills I can bring to a new job, and with the right job, I'll be able to pay my bills and maybe even take a vacation. I have lunch with a coworker, and we talk about our jobs and dreams for the future. And now where are we? We're back at the top of the ladder. Okay. So if one of the things that you got to do in treatment is you got to teach people how to self-monitor and to know where they are on the ladder. And that's not an easy thing, especially if you spend a lifetime trying to not feel. As one of my patients said, numbness is the goal. Bryan, you don't get it? Numbness is the goal. And if you're just going to be a floating head, it's hard to move past. All right, so what do we do with all this information? So as some of you are aware, there's something called the Adverse Childhood Experiences Questionnaire that was developed decades ago. It has some good research literature on it, though. It's a 10-item measure where the person just says yes or no to the items. And it can be read to the patient in case it would be too activating for them to read it. But initial studies have found that it's highly correlated with depression, suicide attempts, likelihood of PTSD, and substance abuse problems. And more recent studies have found it correlated really highly to health problems, all the way from obesity, STD increase in broken bones, heart disease, liver disease, and even some forms of cancer. Basically, a score of 1, and I'm going to go through them with you real quick if we have time. Is this right? I have 55 seconds left, or did that get messed up? I have a minute 40. Okay, I will not be reading you them, but they are in your packet if you want them. But a score of 1 means you're with 50 to 72% of the adult population. A score of 4 or higher, and you're correlated with some of these negative outcomes that we've talked about. Now, I won't go through them all, but they're in your packet. You can devise a very easy strategy to administer this. And so what you would, ideally, what would be wonderful to do in the ideal world is we have clinics where they administer the ACE-Q to their patients. And with patients that get a score of 4 or up, you administer an additional item called the PCL5, and the reference for it is here. It's a free measure. VA uses it all the time. And if a patient has both a positive ACE-Q and a positive PCL5, the instructions to score it are right there. It takes the patient less than 2 minutes, and it's going to take you less than 2 minutes to score it, or an MA to score it. If both of those hurdles get passed, then that's probably somebody that needs to get triaged to psychiatry or to work with a therapist earlier rather than later, because your first-line treatments probably are not going to work. They probably aren't going to work. A brain on cortisol is very different than a brain that's not, and it responds differently. Okay, so that's our information. My packets have other information as far as references for what I've said and also for the different instruments that I've used. But now I have a whole 1 minute. You gonna give me 5? But that's my contact information on there right now if anybody has additional references. I do have the Lannis reference. I didn't update my slides, but if anybody wants that, my email is on the packet, so you can email me there. Thank you.
So, questions?
Yes, we have a lot of stressful things in our world around us, and it seems like there's also more people describing themselves as being diagnosed with PTSD. Is there any data to say there's more PTSD now than there was a generation ago or 2 generations ago, or are we just diagnosing it more because of awareness of the diagnosis?
Yeah, it reminds me of autism. I mean, autism rates have skyrocketed, and you kind of at some point say, is that because we're better at catching it, or is that because there's something in the water that's, and it's really a chicken or the egg scenario, but given the onset of what happened with COVID-19 and the other things, I think there's good research to indicate that there is a higher level of stress, which is weird because we have higher GDP than we've ever had before in this country, but the way that we're processing information seems to be different. And I could go into another half an hour about possible speculations as to why, but we do have some good data to suggest that it's gone up, especially with Gen Z and millennials. And I could go into a whole thing about social media and the interaction there, but that would just be me ranting, I guess. Yeah.
I think kind of blending into the same topic is when you were talking about the shoulds versus reality.
Yeah.
I'm curious if, in large part, some of the increased PTSD we are seeing is people's perception of what they should have versus what reality really dictates.
Yeah.
And if there's any, like, my second question with that is if there is any, like, preventive strategies in teaching people that life is kind of hard and maybe what you think should exist or should happen is different than what really happens.
You know, I think that's a really great point. I mean, the part of me that's kind of more geared towards Buddhism would say all of life is suffering. And, you know, if we can kind of help, especially with the rising generation, to kind of recognize that, because there is this massive discrepancy between our expectations and the reality. Expectations are interesting things. If you don't have them at all, you don't challenge yourself. But if you make them too rigid and too high, you make life much more difficult. So I think there is some good research showing that we're trying to do that in schools as far as kids to use mindfulness and be aware of these other kind of strategies, but the data is not out yet on whether or not those are effective. It could end up being like the DARE program. We don't know yet.
Hi, thank you for your talk. I was curious what your insights are on the effect of neglect and how that might be traumatic and what your thoughts are.
Disconnection is traumatic. Disconnection is traumatic. I mean, it doesn't fall under people's definitions of big T trauma, right? But in my experience, and it's just my experience, is that dealing with neglect can sometimes even be more difficult than dealing with simple PTSD because you have a long history of just not mattering. Disconnection is traumatic.
I recently met with an Air Force recruiter, and they were recruiting here in our high schools. They could hardly find people that weren't on drugs. These young kids that had so much stress, and we use them way too much. And we need to start looking at other ways to do that and treat them, maybe what you do, counseling or stuff, but way overuse on drugs. They couldn't even come anywhere near their quota in recruiting these young kids. Life is a bitch, and it's tough.
Yeah.
And I disagree with you on spare the rod and spoil the child. I think that really works.
Well, I don't know how long you guys want me to speak. It's like you guys are triggering me and just baiting me. I don't know. No, look, as far as the medication kind of stuff goes, I'll say a couple of things. The increase in pot, I don't think has been helpful with trauma. I'm fine with people using, I shouldn't say this, I'm going to. I'm fine with people using pot if we're talking about chronic medical pain, things like that. I don't know as if I'm a huge fan of pot when it comes to anxiety, though. And I also have some hesitations with Xanax, Klonopin, the benzodiazepines. Fine with SSRIs. SSRIs, nobody knocks over a drugstore and steals all the Prozac. But it's very difficult, and I say to my patients quite frequently, if you're taking this amount of Xanax, like 3 or 4 doses a day, you can come to therapy every day and you're not going to get better because you have to do exposure work, which means being able to feel something and be able to do something different with it rather than immediately numb out. And I think sometimes benzos, pot, they haven't made my job easier. I think they've made it quite a bit harder, although people say all the time that they're doing it medicinally.